G'day team, and welcome to Overheard in the Emergency Room, the podcast where we cut through the noise and discover what really makes us healthy and happy in the long run. I'm your host, Dr. Cois, a former strength and conditioning coach and current emergency medicine specialist. Last time out, we talked about our two-tiered blueprint for longevity. Today, we'll take the next step in understanding one of their most important foundations. Let me ask you something. If I had 30 seconds in the emergency department to give someone nutrition advice, what do you think I'd actually say? I certainly wouldn't be talking about keto versus vegan. It wouldn't be advising someone to never eat carbs again. And I wouldn't have some flashy spiel about how this one Andean mountain fruit melts belly fat. Because in the real world, people don't need more nutrition clickbait. They need a repeatable pattern. In today's episode, we'll discuss our first tier 1 intervention. Diet. By the end of this episode, you will understand a simple, evidence-based way to eat. The kind of advice that holds up across national diet guidelines, cardiovascular society guidelines, and the big long-term studies performed by actual nutrition scientists and epidemiologists. So strap in and enjoy the ride as we continue on the road to less bad days and more good decades. So let's start with a case. A 34-year-old man comes into the emergency department with chest and epigastric pain for a few hours. No vomiting, no big dramatic story. He's just worried, and honestly, he should be. Chest pain gets everyone's attention. We do what we do. We get an ECG, labs, troponins, a chest x-ray. We rule out the scary things. Doesn't have a big heart attack, a pulmonary embolism, or a big bag pneumonia. The workup really isn't that worrying, but his blood work shows mildly elevated liver enzymes. I order an ultrasound, partly to check the gallbladder, partly because something just isn't right. He's a young guy. He shouldn't have abnormal liver tests. The ultrasound report comes back while I'm busy treating other patients, and there it is. Fatty liver, what we call non-alcoholic fatty liver disease. Now, here's what matters. He didn't come in saying, "Doc, I think I'm metabolically unhealthy, and I'm worried about my liver and how it may be riddled with fat." He came in with chest pain, and we found this incidentally. And that's the thing about diet-related disease. It's often silent until it isn't. Let's dig into this case a little more. He's slightly overweight, he has mildly elevated blood pressure, and he eats a typical American diet, rich in ultra-processed convenience foods which lack fiber and have little whole food structure. And in that moment, I'm thinking, we did the emergency medicine part, but now we need the prevention part, without a lecture, without shame, and without pretending it's simple. So, what do I say? Today, I'll give you the exact version of my elevator pitch for nutrition in the ED that I would use for him. But first, we need to build the evidence base so it doesn't sound like just another opinion. If you've ever spent any time in the social media nutrition world, you'll know that it is wild out there.
Animal-based diet is centered around consuming the most optimal foods for humans. According to followers, that's meat, organ, fruit, honey, and raw dairy. It's essentially like carnivore without the scurvy.
I'm in Costa Rica with Dr. Paul Saladino to learn more about the lifestyle and why a guy with salad in his name doesn't have any.
I'm excited, but I'm also scared because I feel like every food that I love, I'm gonna have to hate it by the end of this.
That's not the goal.
In this short video, I'm going to give you some practical tips, advice, and steps on how to start your carnivore diet if that's what you've chosen to do. I'm Dr. Ken Berry, a family physician with over 20 years of clinical practice, and I've been a carnivore for almost 5 years now. And I talk about why I chose carnivore and why I stuck with it in other videos.
This is what I'm eating for breakfast as a 39-year-old who developed major chronic illnesses like Crohn's, IBS, severe bloating, pre-diabetes, chronic fatigue, migraines, candida, low testosterone, hypogonadism. My life quality was terrible, and because I was eating things growing up like soda, candy, cereal, so much meat, milk, mac and cheese, unlimited fried food, fast food, I got really sick. And through eating a fruit-based diet, juicing, and water fasting regularly, I've reversed all these conditions that the doctor said were.
Bill Bradley, registered dietitian here. Today, we are going to talk about the authentic Mediterranean diet.
Now, when I first became a dietitian, I worked in a hospital, worked with people with heart disease, and I learned about the Mediterranean diet.
I plan to live to 100 by following this complete vegan nutrition guide developed by our team using the latest nutrition science and insights from thousands of clients that we've worked with directly. This strategy is not about giving up your favorite foods. It's about adding the right foods and some strategic supplements to help you avoid deficiencies. And
here's where we're going to go with today's episode. We'll talk about the major dietary guidelines and what they actually agree on. We'll understand where that evidence comes from and what kind of evidence actually exists. We'll talk about why people hear guidelines and all of a sudden their eyes glaze over. We'll understand the role of ultra-processed foods and the modern food environment. We'll discuss a simple, repeatable way to eat and end the episode with 3 changes you can start this week. But let's not bury the lead. The healthiest dietary pattern is mostly whole, minimally processed food, especially plants, with enough protein, lots of fiber, and minimizing or completely omitting processed calories. That's the backbone. Now, let's earn it. Here's the first mindset shift. A healthy way to eat isn't a single diet, it's a pattern. And what's interesting is that when you look across different countries, US guidelines, Australian guidelines, heart health guidelines, the differences are mostly cultural packaging. The core is remarkably consistent because biology doesn't change just because you cross the border. When you zoom out, the pattern is as follows. More vegetables and fruit, more legumes, nuts, seeds, more whole grains, more unsaturated fats, think olive oil, nuts, fish, less added sugar, less refined grains, less sodium heavy packaged foods, less red and processed meat, and lower saturated fat with a focus on higher fiber. Now, notice what's missing from that list. It doesn't say never eat bread, never eat rice, eat only at 6 a.m., do a detox. It's not drama, it's structure. And if you're listening and thinking, that sounds boring, I get it. But boring is powerful because boring is repeatable. Nutrition evidence comes in layers. Layer 1, mechanisms. We know some basics from metabolic ward studies or very short-term controlled studies. Fiber improves satiety, gut microbiome constitution changes with different types of foods. Saturated fat raises LDL, high sodium increases blood pressure in susceptible folks. Ultra-processed foods tend to be energy dense and easy to overeat, and they're relatively devoid of nutrients in a lot of cases. Mechanisms are helpful, but they don't tell us the full story of real life. We know about these mechanisms from studies where we can tightly control every aspect of an experiment. Typically, patients are locked in a facility where everything that goes into and out of their body, yep, that's food and poop, can be collected, weighed, and we can see what changes happen to their body. Things like cholesterol levels, blood pressure, body weight, gut microbiome, and metabolic rate. These are great studies, but the reality is that when out in the wild, almost no one eats the way they do during a metabolic ward component of any study. Layer 2, short-term clinical trials. These are studies where participants are fed a diet for weeks or months and various physiological parameters are measured. Factors such as blood pressure, LDL cholesterol, weight, and blood sugar levels. These types of studies are really good for understanding how certain foods change physiology and therefore the risk of disease, and often are more reflective of real-world scenarios. But short-term trials don't always answer questions like, does eating this way reduce a heart attack risk over 15 years? Which brings us to layer 3, long-term cohort studies. This is where the big cohort studies come in to help us understand the diet-chronic disease relationship and the outcomes that go with it. These are studies that follow tens of thousands, sometimes hundreds of thousands of people for years and decades. They ask what people eat, usually with food frequency questionnaires, then track outcomes like cardiovascular events, diabetes, cancer, and mortality. Cohorts are not perfect. I'll say that out loud. But they're one of the best tools we have for understanding questions like what dietary patterns tend to associate with better long-term health in the real world. The predictable criticism. It's just questionnaires. Yes, nutritional epidemiology often uses dietary questionnaires. But here's the thing. If the criticism is it's hard to measure diet, that's true. But if the criticism is, therefore, all things and findings are meaningless, that just doesn't follow. Because these questionnaires are validated with repeat measures to reduce random error, and when multiple cohorts in different places find similar patterns, that consistency matters. So the right approach isn't trust everything or trust nothing. The right approach is triangulate. When guidelines align with cohort patterns, short-term RCT's effects on risk factors, and plausible mechanisms, that's when our confidence increases. So I'm going to give you a second case before we dive into our discussion on dietary guidelines. A 45-year-old woman comes in with a severely elevated blood pressure, 191/135, and a right-sided temporal headache. In case it didn't immediately stand out to you, that number for blood pressure should be alarming. So we do the right thing. We evaluate for hypertensive emergency. We check kidney function, an ECG, a troponin, and get a CT head. The workup is reassuring. There's no stroke, no bleeding, no acute organ injury. We treat the headache like a migraine, and she improves. Then we hit that awkward moment in emergency medicine. Her immediate crisis is over. However, her long-term risk is still visible right there on that screen. Now, yes, she may need a medication. Yes, she needs a follow-up at primary care. However, lifestyle matters here, as blood pressure is deeply linked for many people to sodium intake, excess body weight, physical activity levels, sleep patterns, alcohol consumption, and the way that folks build their diet can be a powerful tool to help many of the factors that contribute to elevated blood pressure. And this is where the diet wars are so unhelpful, because what she needs isn't a perfect diet. She needs a direction, and she needs changes that match real life. So let's talk about what those changes should look like. So as of 2026, the American dietary guidelines are about to be updated. And the current administration gets a big fat F from me so far when it comes to their performance on public health. So let's see this segment as a primer so that you understand what drives the guidelines. And I think you'd be surprised at how they are actually created and what the scientific report recommends for the current 2025-2030 cycle. But before we do that, let's take a sneak preview of what RFK Jr. and his nutrition advisors are likely to be dropping when it comes to the guidelines, and then we can see what the scientific recommendations are and what they chose to ignore.
Is set to release new MAHA dietary guidelines in the new year.
Among some of the expected changes, a focus on whole foods, encouraging people to eat more meat, full-fat dairy, and saturated fats, rejecting the emphasis on plant-based proteins, and discouraging the consumption of ultra-processed food.
When looking at many guidelines, including the American, Australian, American Heart Association guidelines, they are remarkably similar and support my elevator pitch. Let's look closer at the US dietary guidelines. They are set forth by the USDA, and they drive a significant portion of federal policy, including the types of foods supplied by public schools. The USDA generate guidelines based on recommendations from scientific papers created by nutrition experts, following an extensive review of the literature every 5 years. The US Dietary Guidelines for American Scientific Statements provides a great primer on how they are created. A group of nutrition experts is commissioned every 5 years to work for 2 years answering critical questions about how to improve dietary recommendations for Americans and reduce the burden of diet-related chronic disease. One of the guidelines advisors, Dr. Christopher Gardner, recently talked about his role on the Sigma Nutrition podcast.
On Zoom calls, we got split up into 4 different subcommittees. Every one of the 20 members was on 2 subcommittees. We started off with 80 questions that we were given and asked to rank them and told you won't possibly be able to answer 80 questions. Prioritize them. We prioritized them. And then we had to go through the process before looking at any of a team of about 20 federal staff members from both Health and Human Services and the U.S. Department of Agriculture that did the literature searches for us. This is amazing. I mean, we were working for free, so this was a really good deal. We would set up the PICO guidelines, and PICO is a very standardized approach to this. P stands for population, and then I stands for the intervention. What kind of exposure would you be talking about? Is it exposure to beans or red meat or dairy? And then C was the comparator. What would you be comparing that intervention to? Is it just eating less of the same thing versus more? Or is it eating something else? O would be the outcome. Does this have to do with cardiovascular disease, mortality and morbidity? Or is this just cholesterol? Or are we talking about snacking and just behavior? Or are we talking about weight? And then the T was, should there be a cutoff here? Should we exclude the studies that don't meet these time criteria? So, Danny, in the beginning,
quote from the scientific report sums up the mandate of the scientific group in designing the report. The committee was tasked with examining the relationship between diet and health across all life stages, using health equity lenses, ensuring that implications of factors such as socioeconomic position, race, ethnicity, and culture were described and considered to the greatest extent possible for each scientific question and based on the information available in the scientific literature and data. A primary goal of centering health equity is to help HHS and USDA ensure that the resulting guidance in the dietary guidelines for Americans is relevant to people of diverse racial, ethnic, socioeconomic, and cultural backgrounds, thereby increasing the potential of the guidelines to meet nutrient needs, promote health, and reduce risk of chronic disease. They sought to evaluate new topics, including food sources of saturated fat consumed and risk of CVD, dietary patterns with varying amounts of ultra-processed foods, strategies for improving diet quality and weight management, which involve new reviews on portion sizes and frequency of meals and/or snacking, and practical guidance about how to feed younger children in terms of caregiver feeding styles and practices that support children's consumptions of healthy foods. The Dietary Guidelines Advisory Committee looked at dietary patterns that are associated with chronic diseases such as diabetes, cardiovascular disease, overweight, and obesity, and many types of cancer, including breast, colorectal cancer among them. Age-related cognitive decline, dementia, and mild cognitive impairment were also included. The dietary pattern that consistently emerged for individuals aged 2 and older was one that is higher in vegetables, fruits, legumes, which include beans, peas, and lentils, nuts, whole grains, fish and seafood, vegetables, oils that are higher in unsaturated fat and lower in red and processed meats, sugar-sweetened foods and beverages, refined grains, and saturated fat. These patterns also included consumption of fat-free or low-fat dairy foods lower in sodium and/or may include plant-based dietary options. The 2025 guidelines recommended keeping saturated fat in the diet under 10% of calories. This holds true in the newest scientific report, which recommends swapping butter, processed and unprocessed red meat, and dairy, and substitute it with a wide range of plant-based food sources, including plant-based proteins, beans, peas and lentils, whole grains, vegetables, monounsaturated fat, and polyunsaturated fat in the form of vegetable oils and spreads. These foods are associated with a reduced risk of cardiovascular disease. The scientific report also discusses complementary foods and beverages up to 24 months of age and the importance of repeated exposures and cultural acceptance of foods that have no evidence of negative outcomes, including fruits, vegetables, and whole grains. Here's a common line. If dietary guidelines are so good, why are we getting sicker? And the simplest answer is that most people are not actually eating anywhere near the recommended pattern. Not because they're lazy, but because the environment they live in is really powerful. Ultra-processed foods are cheap per calorie, fast to prepare, engineered for taste, aggressively marketed, and they're everywhere. There's literally a year's worth of calories available on every street corner convenience store, drugstore, and gas station. If you're tired, stressed, time poor, and trying to feed a family on a limited budget, the default options often push you towards ultra-processed calories. And eating this way crowds out the fiber, the micronutrients, the protein structure, and the volume per calorie you get from whole foods. Let's talk about a couple of papers. A study from 2023 reported the adherence to food-based dietary guidelines in high-income and low-middle-income countries. The authors did a systematic review looking at populations of healthy children and adults aged 7 to 65 years, using an observational or experimental design, evaluating adherence to national food-based dietary guidelines. They found that almost 40% of populations in both countries do not adhere to their national food-based dietary guidelines. Fruit and vegetables were most adhered to, and the prevalence ranged from 7 to 63%. Grains and dairy were consumed below recommendations, while consumption of animal proteins, particularly red meat, exceeded the recommendations. So this begs the questions, what would happen if folks actually followed the guidelines? Well, a paper from 2023 conducted an analysis to explore the associations of eating a dietary pattern that was aligned with dietary guidelines with another well-known dietary approach, the Mediterranean diet, and assessed the relative risk of diabetes with the two types of diets. The data were derived from the National Health and Nutrition Examination Survey and included over 20,000 participants. They found that high adherence to the 2015 dietary guidelines for Americans as compared with the Mediterranean diet was more associated with a lower risk of prediabetes among adults in the United States. Notably, among component food groups and nutrients, higher intakes of red and processed meat, sodium, and total saturated fat were associated with a higher risk of diabetes. A 2019 study on a Spanish cohort that was recruited between 1999 and 2014 had their habitual diets assessed and scored for adherence to the 2015 dietary guidelines for Americans. After adjusting for demographic and lifestyle factors, high adherence scores were found to be associated with a reduced risk of all-cause cardiovascular and cancer mortality compared with low adherence scores. A 2-point increase in adherence on a 21-point scale was linearly inversely associated with all-cause mortality. So the more closely patients adhered to the guidelines, the less likely they were to die from any cause. The main sources of difference between high and low adherence were in whole-fat dairy products, red and orange vegetables, fresh fruits, red meat, and dark green vegetables. The bottom line here is that many long-term health outcomes are improved with greater adherence to dietary guidelines, a finding consistent across cohorts worldwide, which likely explains why many of the guidelines around the world look very similar. Let's examine the visual representations of guidelines from around the world. Starting with my home, Australia, and their guide from 2013. You can see that over 2/3 of the plate consists of fruits, veggies, and whole grain products, including my favourite breakfast, Wheat Bix, because Aussie kids are Wheat Bix kids. Then,
Wheat Bix is #1. From Aussie kids to grown-ups, it's loved by everyone. Aussie kids are Wheat Bix kids. Aussie kids are Wheat Bix kids.
Then, a sixth of the plate is low-fat dairy and soy milk, and the protein section is half legumes, soy products, 1/4 seafood, and the remaining quarter of that section is red meat and poultry. Then, to the UK, which is very similar to Australia, making a lot of sense given their shared historical cultural identity. They also recommend prioritizing beans and pulses over fish as sources of protein. Then we head to the US close neighbor, Canada. These guidelines came out within the last 3 to 4 years, and they are brilliant. They revamped the entire process and had scientists create this eating guide, and I love it. 3/4 of the plate is fruits, veggies, and whole grains. Then the remaining quarter is your protein, which emphasizes beans, legumes, nuts, and tofu. There is a limited amount of poultry, fish, and red meat recommended. So 3 countries which are really very similar culturally to each other, and the US really agree when it comes to their national guidelines. What if we look further afield to countries with different cultural identities? Let's head over to Norway and see what their guide shows. Now, I don't speak or read Norwegian, but a picture tells 1,000 words, and you can easily see that the similarities with the 4 previous countries continue. They even allow a small sliver of sweets and treats as part of the plate. Then we can swing down from Northern Europe to Japan. The daily foods are dominated by grains, including rice, bread, noodles, pasta, and veggies, with the remainder being fish, eggs, soybean dishes, and meats, as well as fruits and milk products in smaller servings. So, instead of asking, are guidelines wrong? A better question is, what makes adherence hard, and what helps people stick with it? One of the themes that shows up is self-efficacy, not motivation, not discipline. Self-efficacy means that you feel capable, you have the skills, you have a plan, and you know what to do when life gets messy. So education and knowledge, that's what we're building today. There was an interesting study out of Japan. This was a dietary intervention study using the dietary approach to stop hypertension, the DASH diet. Adherence to a DASH-based diet is associated with lower risk of hypertension, coronary artery disease, and insulin resistance. Briefly, the DASH diet is a whole foods, plant-predominant diet that focuses on fruits, vegetables, whole grains, lean proteins, and low-fat dairy. all the while reducing sodium, sugar, and saturated fats. The dietary approach used in this study is the DASH Jump, a low-calorie version of the DASH diet, specifically designed for the Japanese population. The investigators aimed to determine the subject's self-efficacy regarding making changes to their lifestyle behaviors. The dietary intervention included delivery of DASH Jump foods for 1 month and then normal diet for 4 months. They demonstrated that a DASH-style diet enhanced self-efficacy and improved several physical parameters, including a 5 to 10 kilo weight loss and a 10 to 20 point reduction in systolic blood pressure. So what's making folks change their behavior? Well, in this study, the subjects had their meals delivered to them, which ensures adherence, of course. But what's unique about this study is that they looked at what helped the subjects to continue adhering in the intervention after the delivery stopped. Most prominently, seeing improvements in physiological data, having had success in the past with lifestyle interventions, and higher self-efficacy, better knowledge, were the 3 main reasons folks were able to successfully change their behavior. This is why we're here today, to learn. I want to make this very complex topic simpler and easier to understand with actionable steps you can take today. That's why I think an elevator pitch works, so that you know what type of pattern to follow when planning your meals for the day. I want you to think about your plate and aim to make it 80-20. About 80% of what you eat by habit comes from fruits and veggies, legumes and beans, whole grains, nuts and seeds. The remaining 20% is the human part. Cultural foods, celebration foods, restaurant meals, and things that make life enjoyable. The reason this works is not willpower. It works because it changes the default. It increases fiber, volume, micronutrients, and satiety. Eating this way also decreases calorie density, excess saturated fat, excess sodium, and the ultra-processed, easy overeat category. It is also important to tailor certain aspects such as protein to the individual needs. Beans, lentils, soy, seitan ideally make up the majority, but preferencing fish and poultry if they consume animal foods can also be part of a healthy dietary pattern. And the data is clear. It is important to reduce the frequency of red and processed meats. That's it, not a diet, but a pattern. It would also be remiss of me not to mention the role of a multidisciplinary team. For those of you who have a primary care provider, it is important you talk to them about diet and see if you can get a referral to a dietitian. These folks are trained in helping patients make dietary choices that fit with their goals and their lifestyle, so that changes stick. Make a phone call today to try to figure this out. Now, let's make it real in 3 moves. Step 1, add 1 anchor meal per day. Pick 1 meal that you can repeat on most days per week. Not because repetition is the most amazing thing in the world, but because repetition makes life easier. Here are some examples. Oatmeal. Overnight oats is my personal favorite. Add some fruits, nuts and seeds. Hummus with sauteed greens on whole grain toast. Tofu scramble with veggies. Lentil soup with whole grain bread. If you already have an anchor, great, keep it. Step 2. Do 3 protein swaps per week. 3 times this week, I want you to swap out processed meat or red meat for beans, lentils, tofu, tempeh, fish, or a leaner protein option. This isn't a moral statement. I swear I'm not trying to make you vegan. It's a pattern practice. And step 3, build a friction plan for when you're busy. This is a self-efficacy part. When life gets chaotic, what do you eat? Have a short list of default wins. Bagged salad with canned beans and olive oil with some vinegar. Greek yogurt with frozen berries and oats. A rotisserie chicken with microwave rice and frozen veggies, or pre-cut veggies with hummus and nuts. The goal isn't perfection, but we need to change our environment. The goal is to make the healthy choice the easy choice more often. Alrighty, let's return to the beginning. A 34-year-old with incidental fatty liver. If he adopts the 80-20 plate, increases his fiber, reduces ultra-processed food, and trends his weight and metabolic markers in the right direction, his long-term risk trajectory can change. Not overnight, but over months and years? Absolutely. And the woman with severe hypertension, medications may be a part of the plan, but diet patterns that reduce sodium-heavy ultra-processed foods, support weight control, and increase potassium-rich whole foods can help shift blood pressure meaningfully over time. These are the slow levers, but slow levers are how chronic disease prevention works. So let's recap in one breath. Across the best evidence we have, guidelines, large cohorts, and trials on risk factors, the healthy dietary pattern is boring and consistent, mostly whole foods, plant predominant, high fiber, lower ultra-processed foods, lower added sugars and refined grains, a bias for plant and lower saturated fat protein sources. And if you want a single action from today, pick 1 anchor meal and repeat it. If you want to go further, here's my question for you. What's your one change this week, your one swap that you can keep doing a month from now? If this episode helped, share it with someone who's tired of the diet wars and just wants a plan that works in real life. In the meantime, please like and subscribe to the channel and visit the blog that accompanies this website for more detailed information at drcois.com. Thank you so much for joining me today, and we'll see you next time when we discuss all things exercise as we chase less bad days and more good decades.